I should say good morning or good afternoon, depending where you are watching this from. Thanks for logging in. So I'm just going to give you an overview of what I consider a safe lymphocyte count, and you'll see it's not a simple answer. Point out my disclosures, which are relevant because I'm going to be talking about almost all our disease-modifying treatments today. And our center is heavily involved in translational research, both investigator and commercially led clinical trials, and I sit on quite a large number of steering committees. So what is lymphopenia? So the way we normally define lymphopenia is we take a population of healthy people, in inverted commas, measure their peripheral blood lymphocyte counts, and then define a normal range based on the 2.5th and the 97.5th percentile. In other words, 2.5% of the population is considered to have an abnormally high or abnormally low based on the standard format. Now, the problem when you do this is that the lymphocyte counts will vary depending which population you study. And so you'll get different normal ranges across the world. And that actually happens is if you get blood reports back from, say, a patient who's coming from abroad, you often see that the lymphocyte range is slightly different to the one that's quoted by your laboratory. So the WHO tried to standardize this by putting forward an international, a global standard, which they've classified as grade 0, which is normal, a lymphocyte count of 1,000 lymphocytes per cubic millimeter. That'll be 1 times 10 to the 9 cells per liter. And then they've got these 4 grades based on cutoffs of grade 1, 2, 3, and 4, and the cutoffs are 800, 500, 200. And I think most of you will be aware of these cutoffs. Now, the problem with the lymphopenia counts is that things change with time. And so if you are immunosuppressed and have a lymphocyte count that's lower, the risks associated with the lymphopenia will accumulate with time. And also there's the issue of aging as well, and also whether or not you have previous immunity to whatever infection you're exposed to, or the other cytopenias that are combined with the lymphopenia. So if it's lymphopenia in isolation, it's slightly different to somebody who's lymphopenic and also neutropenic, obviously. What I want to point out is that the WHO classification is really not based on science. It's a little bit of a thumbsuck to make it easy for people to remember. And this is actually probably the best study from Denmark, where they looked at lymphopenia and actually risk of infection and infection-related deaths in almost 100,000 Danish people based on their national register. And if you see on this, slide over here, you can see that when you put the lymphocyte counts on the x-axis and you look at hazard ratio, you can see even when you hit 1, there's an increased risk of getting infections. And so if you had to use infections or infection-related deaths as a marker of what is a normal lymphocyte count, you'll see that the lymphocyte count should probably be set at about 1.4 at a population level. And actually, there are some laboratories in the world that will report their lower limit of normal for a total lymphocyte count of being 1.4. What I've tried to do is map the WHO classification system onto the curve. And you can see that as you go up with the WHO, the risks go up. So even at a WHO 1, having a lymphocyte count of 1,000, okay, or 1, you've got a 20% increased risk of getting infection compared to their baseline, which is around about 1.4. And by the time you get to WHO, it's 2.10. But you can see the risks really go up once you go to grade 3 or 4. So at a population level, the WHO classification system is probably not ideal. We've stuck with it. And that's what's used in clinical trials, and that's what's reported by regulatory authorities. But the real risk of infection and infection-related risk really ramps up when your lymphocyte counts drop below 500. The other thing that's not taken into account is age. So I'm not going to spend much time, and I'll give you these slides if you want them, But immunosenescence is a real issue. So a total lymphocyte count of 500 in a young person is a completely different beast in somebody who's older, particularly somebody who's over the age of 60. And there are lots of things that happen in terms of the immune system as you age. You get thymic involution, your repertoire goes down, which is very, very important, particularly in relation to immunity to new infections like the SARS coronavirus 2. You get a much smaller number of naive T cells. There's problems with homeostatic proliferation. And what happens is your immune system, as you get older, spends most of its time looking after what I would call latent herpes infection, so CMV and EBV. About 70% of the peripheral lymphocyte counts in somebody who's over the age of 60 and 70 is responsible for controlling CMV and Epstein-Barr virus. Whereas in a younger person, that's much, much smaller. You don't need as many peripheral lymphocytes to control it. We know that vaccine responses are poor as you get older. So there's lots of issues related to aging and immunosenescence that need to be taken into account. And this is a review discussing immunosenescence. And I just want to point out, so looking at the purple line there, the so-called overall T cell receptor diversity, you can see it drops dramatically from about the age of 60. And what that really means is, as you get into old age, in your peripheral blood, instead of having a wide repertoire, lots of T cell receptors, you get a very narrow repertoire with the predominant clones targeting cytomegalovirus if they're infected, or Epstein-Barr virus, which means that the proportion of cells, T lymphocytes, that are naive and have the ability to respond to novel infections like SARS coronavirus 2 is limited. And that's why you have to interpret the lymphocyte count in terms of the age of the patient. So if you've got anybody who's over the age of 60, okay, you have to assume they got immunosenescence, reduced repertoire, and an inability to respond as well to new infections. It's grey. I'm not saying 60 is definite. It also depends on not only your biological age, but there's also the physiological age, is how old somebody is. It needs to take it into account. An example of this, it's well known that PML risk goes up with age, and we've seen this particularly with the dimethyl fumarate cases. The initial cases occurred in people with lymphocyte counts above 500, and then we saw a sprinkling of PML cases in people who were above 500 lymphocyte count, and they tended to always be elderly patients. And similarly, there's a background incidence of PML in the general population, and it's not linked to immunosuppression. And all the cases I've seen, and I've seen 3 in my career, have all been people over the age of 70. So I think you have to treat old age as being potentially immunosuppressive and a compounding factor when interpreting lymphocyte counts. The other thing is, it's not just about lymphopenia. So if you've got deficits in any of the other arms of the immune system, like you have problems with neutrophil function, okay, then you're going to get bacterial infections and fungal infections. And this is relevant to HSCT, that drops neutrophil counts. And also if you're still using mitoxantrone, which is used in other parts of the world, initially you may have a neutropenia associated with that. Obviously, if you've got abnormalities of T cell function with monocyte problems, then you're also going to be exposed to opportunistic type bacterial infections, mycobacterial infections, nocardial hysteria, fungal infections, viruses, and parasites. And obviously, if you have a problem with antibodies, humoral immunity, so you've got hypogammaglobulinemia, this is where you get infections with the encapsulated bacteria. These are bacteria that have glycoproteins or sugars around them. And this is particularly important for strep pneumonia and all the gonococcus, Neisseria meningitidis, and Haemophilus influenza as well. So these are the types of things you have to keep in mind. It's not only lymphocyte counts. What other immune abnormalities do you have? Now, in terms of the SARS coronavirus 2, we have to rely on some studies done with the coronavirus 1 infection. And it's quite clear that when you look at the lung, what's responsible for clearing the infection in the lung is innate immunity initially, both neutrophils, macrophages, and CD8 positive T cells. And there are very few natural killer cells and B cells in the lung lesions, okay? And so the dogma is probably correct for coronaviruses, that what clears them is cytotoxic CD8 positive T cells with the help of macrophages or monocytes. Obviously, to prevent secondary infection, reinfection, or getting infected with another SARS, there again, it'll be memory CD8s, possibly memory CD4s as well, because they need to be present to help antibody production and also neutralizing antibodies to the virus as well. And so this is actually supported by a case study from an Australian patient. This was a patient who arrived in Australia and then went on to develop COVID-19. And you can see that they were studied from about day 4 when they arrived. And you can see that antibody production, okay, so in this box here, IgG, IgM, antibody production started from about a week, okay. And when you look in the peripheral blood of this patient, you can see antibody secreting cells, okay, are found after the first week, and the T helper or follicular cells go up with time. And similarly, the CD8 responses are much more marked than the CD4. This is a proliferative response, specific cells. Okay, and also compared to controls, there was an obvious monocyte response. It doesn't look that prominent on the graph on the left, but you can see on the graph on the right, there was a definite increase in monocytic cells expressing CD14. So the immune response to the virus takes time to ramp up. And I think what's quite clear is the initial response is driven by monocytes, followed by CD8 positive T cells, and later on the B cells kick in. Since then, there have been these 2 very interesting case reports from Italy. So these are 2 males that had X-linked 8 gamma globulinemia. So as you're aware, the condition is lethal in women. So it's males who get this condition. These males don't have B cells and they make no antibody. All right, so these patients now are often treated by bone marrow transplant or gene therapy, but they can be looked after by intravenous immunoglobulin, and these patients were managed by IVIG, which gives them population immunoglobulins, which, because the population is naive to coronavirus, it's not going to protect them. But I think the message here is that these 2 patients without B cells managed to survive COVID-19. So this actually tells you that you don't need a B cell response to recover from COVID-19. Now that's important because some of our therapies are specifically targeting B cells, particularly the anti-CD20s. And so if you want to use this as an analogy for the anti-CD20 therapies, you need to answer the question that people without B cells are likely to respond and deal with coronavirus without any problems. So this is just a summary slide. So in terms of viral control, innate immune responses are important. And CD8 positive cells are important. We expect antibody responses may be needed, but they're not essential. Okay, and obviously, if you talking about IgG and IgA responses, those require T cell help in terms of class switching and affinity maturation, and that often is driven by CD4 T cell. In terms of prevention of reinfection, so this is based on other animal studies. The IgG response is important with the T cell help. And again, you need innate and antigen-presenting cells and CD8 cytotoxic T cells for prevention of this is called immune memory. So now that's kind of the context of COVID-19. And now we're going to go on to the lymphocyte counts in relation to all of our therapies. Just some background. As you know, our treatments are I classify them as either maintenance, continuous treatments, or immune reconstitution therapies. And the difference between these is that maintenance therapy is given continuously, whereas immune reconstitution therapy is given as pulses. It could be one pulse, for example, with HSCT. With mitoxantrone, it's multiple pulses. And with alemtuzumab and cladribine, it's just 2 courses in year 1 and year 2. And you'd only give additional courses if there's breakthrough activity. So a maintenance therapy, by definition, is reversible. In other words, when you stop the treatment, your immune system comes back to what it was, and MS doesn't go away. It's presumably the mechanisms that are driving MS reoccur. Whereas with an immune reconstitution therapy is depletes the immune system, it allows the immune system to reconstitute itself. So when it's back, it's competent. And I mean competent in the sense that it can fight infections, it can respond to vaccines, and it can survey the peripheral body for tumors. And we assume the MS mechanisms are not there, either because they've been depleted or regulatory mechanisms come back and keep the whatever's causing MS at bay. And this is the principle behind immune reconstitution therapies, is that you recover your immune function, but leave MS in remission. So let's go through the therapies we use. I've taken daclizumab off, as you know, it was withdrawn. But overall, almost all our therapies, except for interferon, glutamate, and I put teriflunomide in orange there because teriflunomide doesn't have an immunosuppressive signal, and in my mind, it's an immunomodulatory treatment and should be colored green. And the way the regulators define immunosuppression is anything that causes a significant lymphopenia. And this is where the debate is what is a significant lymphopenia? And most of the time, they probably refer to an 800 cutoff. You have to see opportunistic infections as well, which goes with lymphopenia. You have to have reduced antibody responses to vaccines and be associated with secondary malignancies. Now, you don't have to tick all these boxes to be called an immunosuppression. Just ticking 1 or 2 of these boxes is often sufficient for the regulatory authorities to label your therapy or particular treatment as immunosuppressive. But these are the 4 criteria they use. Often when the pharmaceutical industry put in a drug for licensing, information on the last 2 is not available. They haven't done a vaccine study, and they don't have enough long-term data to be confident about secondary malignancies. So the call is really based on lymphopenia or opportunistic infections. And again, sometimes opportunistic infections don't emerge until after the therapy is licensed and more patients are treated. But the regulatory authorities would label something as being immunosuppressive just based on a significant lymphopenia. Just to say that this is an illustration just to get across the message that over time, if you've got persistent immunosuppression, the risks go up with time. So things like skin malignancies, basal cell carcinoma, squamous carcinoma, lymphomas, cryptococcal infection will emerge with time. And this is exactly what happened, for example, with fingolimod. And obviously the signal will emerge sooner the more immunosuppressive it is. So with fingolimod, for example, the skin cancer risk emerged around years 3 and 4. The lymphoma risk has taken about 5 or 6 years to emerge. And the cryptococcal signal emerged about year 3 and 4. You know, in the transplant, solid organ transplant setting where you're using much more powerful immunosuppression, you see the signal much sooner. For example, in high-risk patients, skin cancer emerges within the first year on triple immunosuppression in transplant, like kidney transplant patients. On the other side here on the right, you can see the immune reconstitution therapies, and those risks are really short-lived in the sense of immunosuppression. So you see it while the immune system is depleted, and once the immune system recovers, the risk disappears. So this is why I always refer to immune reconstitution therapies as having front-loading of risk, and the long-term risk in terms of immunosuppression is very low. This is why we haven't seen things like PML with alemtuzumab or Cladribine, because the immune surveillance mechanisms that keep PML away are intact once the cell counts recover. Anyway, I've published this in an article. It just gives you the attributes of continuous versus short-term. And the good thing about short-term immunosuppression is that the pharmacovigilance burden should go down with time. alemtuzumab excluded because of the secondary autoimmunity. But you can have things like live vaccines and travel without worry, whereas with the continuous immunosuppression, you can't have live vaccines, and exotic infections, for example, coronavirus, is worrisome. I've already shown you that the level of immunosuppression in terms of your lymphocyte count changes with time, age, and the presence of other cytopenias as well. And there's lots of factors you need to take into account, okay, when interpreting a lymphocyte count. This is why I can't just give you a standard figure. This is a normal lymphocyte count or a safe lymphocyte count for this individual. You have to learn how to interpret this in terms of the overall patient. Say, for example, if you've got a patient who's got a positive HPV screen on cervical smear, okay, would you as a clinician be happy with that patient having an immunosuppressive therapy? I suspect not. You'd want to get on top of the HPV, the cervical problem, before you even started immunosuppressive therapy. So for that individual, even a grade 1 lymphopenia may be worrisome. Okay. All right. So this is why there are no golden rules for what is safe. You have to interpret it in terms of the patient themselves. I want to point out that with the S1P modulators, the peripheral lymphocyte count is really unreliable. Very unreliable. The reason being is it traps lymphocytes in secondary lymph node organs, and the peripheral lymphocyte count doesn't correlate with treatment response or infectious complications. So you really have to just manage S1P modulated treated patients. So this would be with fingolimod, siponimod now, alzinumab, by just saying to them, yeah, you're on an immunosuppressive therapy, just be vigilant. The European regulatory authorities tell us to worry when the counts drop below 200. FDA has said ignore the counts, don't even monitor them. Our personal feeling is to be a little bit flexible, because if you use 200 for dose interruption or alternate day dosing or reducing the dose, about 1 in 5 patients on fingolimod would have to have that. And so I'm a little bit more flexible, and I allow the counts to drop below 200 and only really get worried if they drop below 100 in normal times. So what I wanted to say, because natalizumab is a selection adhesion molecule, a blocker, so it blocks VLA4, it actually shifts with the so-called marginating pool. This is the pool of lymphocytes that is rolling along the endothelium in the body. It shifts it centrally. And so the counts go up by about 20%. And it blocks trafficking into various target organs. It blocks it into the brain, the gut, and also reduces lymphocyte trafficking into the lung, which is why I think it may be a treatment for COVID-19, because part of the pathology in the adult respiratory distress syndrome is driven by lymphocytes. What's important in terms of coronavirus is we now know that it's neurotropic. There have been cases of encephalitis. There's been 2 reported. And we're probably going to see more cases as the disease spreads. And so there's this worry that if the virus does seed to the brain, natalizumab would stop immune surveillance, which is why we've shifted all our patients to extended interval dosing. So we know that extended interval dosing, given the drug every 6, 7 or 8 weeks, depending on body size, okay, reduces the risk of PML dramatically by over 90%. And that's presumably because it allows some trafficking, some immune surveillance. And we think the same logic should apply to coronavirus. By doing EID, you're allowing some antiviral CNS trafficking. You should reduce the risk of encephalitis with the virus. And it's based on saturation kinetics. So this is data looking at the alpha-4 integrin occupancy and you can see with extended interval dosing from about 6 weeks to 7 weeks there, you can see it drops, and the natalizumab concentration also drops. And there's this modeling that Biogen have done just to show that there's probably a sweet spot where you get enough desaturation to allow immune surveillance, but not enough to allow MS recrudescence. And so this has been tested right now in a clinical trial, but my personal opinion is would not be to push natalizumab further out than 8 weeks in people that are less than 80 kilograms. And if somebody is above 80 kilograms, I would keep them on a 6-weekly infusion. And I already mentioned fingolimod to you. That drops lymphocyte counts in almost everybody. It traps them and stops them circulating, but they're probably still there. Despite this, though, we do know that people on fingolimod have a problem occasionally with viral infections and severe viral infections. So, we have seen a few cases being reported from the European experience in France and Germany and Italy, people with MS on fingolimod getting COVID-19 and recovering from it. So they do seem to deal with the viral infection. Okay. We do know that this is there is an issue with fingolimod long term. Some people, when you stop the drug, their lymphocyte counts don't recover. So you can see here on this figure here, there's a small scattering of patients on long-term fingolimod where their lymphocyte counts don't recover. The other thing about fingolimod is when you stop it and you release the lymphocytes from the secondary lymphoid tissue, there's a risk of rebound. And the rebound occurs earlier than you get with natalizumab. It occurs around about 6 to 8 weeks. And for this reason, we don't allow lymphocyte counts post-fingolimod to get back to 1 or above 1 before we use therapies like alemtuzumab or cladribine. Because what we're trying to do is just to see an increase. In other words, we're not identifying one of these long-term depleters. And we're trying to get them onto a new therapy if we're switching them before rebound occurs. So that's why in our center, we just watch the lymphocyte counts. As soon as it goes above 800, we retreat with an immune reconstitution therapy, alemtuzumab or cladribine. We're not the only ones that do this. I know the Australian neurologists do this as well. And that usually occurs about week 3 to 4. If you wait to go above 1, which is the guidance for starting cladribine, that takes 6, 8 or longer to occur, and that puts the patient at risk of rebound. Dimethyl fumarate, we don't really know why the lymphopenia occurs, but lymphocyte counts drop by about 30% in all patients, and in about 15% of patients that drop below 800 and about 5 to 6% below 500. The problem about dimethyl fumarate, you have no predictors about who's going to do it. And obviously in the current environment, you have to monitor the lymphocyte counts early on, and most people, as you can see, drop their lymphocyte counts within the first 12 months. And this has implications for starting treatment in the current climate, because if you're going to start somebody on dimethyl fumarate now, you have to measure counts, because you don't want this person to become significantly lymphopenic, particularly below 500, which probably is the zone where you will start having problems with antiviral responses. Okay, so this is an argument that you have to have in place pharmacovigilance or lymphocyte monitoring. So if somebody does develop a significant downward trend on their lymphocyte count, you may want to switch them before they go into a zone where you're worried about antiviral responses. Another thing that's hidden in the total lymphocyte count is that dimethyl fumarate tends to hit the CD8 counts more than the CD4 counts. So this is just one study. This has been reproduced. It's a consistent finding. And you can see on the right-hand side here, the CD8 counts are much more sensitive than the CD4 counts. And you can see the ratio goes up. So a lymphocyte count of 500 on dimethyl fumarate is very different to a lymphocyte count of 500 on other immunomodulatory therapies. That's telling, it means that the CD8 counts are probably lower than the CD4 counts. So you must keep that in mind, okay? Which is why I've always set my cutoff for dimethyl fumarate at 800 rather than 500. And I think it's borne out by the fact that there have been cases of PML occurring in people on dimethyl fumarate with lymphocyte counts above 500. Anti-CD20 therapies, this is just a cartoon showing you that it pushes down B cells to 0 really in the peripheral blood. It also takes T cells down by about 10 to 15% because a small population express CD20. We don't know what that T cell population does, but it does reduce. And this is just showing you the impact of ocrelizumab on CD19 B cells. It drops cytotoxic T cells more than the CD4, so this is the CD8 population. And this is probably why there is a zoster signal with ocrelizumab. The important thing about anti-CD20 therapies is that it gets rid of germinal centers. Now, you might argue, well, big deal. Well, germinal centers are those little factories, okay, where we educate and mature memory B cells. And so what happens in the germinal center is that T cells help B cells to, first of all, class switch from, say, IgM to IgG, IgG 1, 2, 3, or 4, or IgA, and then an affinity matures. So you get high affinity antibodies. And you can see in the anti-CD20 rituximab treated patient, those germinal centers are gone. So this is why patients that are on anti-CD20 therapy don't make very good immune responses to new antigens, okay? And they don't make very high affinity ones, and they often have blunted responses. And this is relevant in terms of vaccines. You can see this publication is now in press, I'm told, but you can see, looking at on the top left here is pneumococcus vaccine. The majority of patients make a very blunted or poor response to pneumococcus. Okay, similarly to influenza is blunted, anti-tetanus is blunted, and yeah, we have the Kiel limpet hemocyanin. So people on ocrelizumab, on anti-CD20 therapies, make immune responses, but they are, from a quantitative, they are depressed. And I would bet to my bottom dollar at a quantitative level, they probably have lower affinity than people who are not on an anti-CD20 therapy. And I want to point out that the pneumococcal vaccine really is a sugar vaccine. It's all the glycoproteins that are in it. And we know that you need affinity maturation to make high affinity antibodies to glycoproteins. So I suspect that when a SARS coronavirus 2 vaccine comes out, and if they're going to use the spike protein, it's extremely heavily glycosylated. All these pink molecules, this is the SARS-CoV spike protein, and you can see all these pink molecules, okay, are sugar molecules. These are glycans. And the virus uses the sugar molecules, which is a post-translational modification, okay, to hide. It's a strategy for it to evade immune detection, okay. And so it's going to be critical that the immune system of people in the general population and our patients have the ability to make antibody, okay, and high affinity antibody to glycoproteins. And so, one of the issues that will be discussed over and over in the next few weeks or months is vaccine readiness. What DMT do we want our patients to be on, or what state we want the immune system to be on? So if they are high risk, they can have the vaccine and respond to the vaccine. Just to say to you that immune reconstitution therapy, this is just showing you the two that are licensed. So alemtuzumab really depletes T cells quite dramatically down to about 0.1 within days of starting it, and the reconstitution is very slow. Cladribine doesn't really knock T cells down very much. It reduces it by about 40 to 50%. Very few patients drop below 500, and I'll come back to that. Important thing is there's no cell lysis it causes cell death by apoptosis. Apart from VZV, we haven't seen a opportunistic infection signal with Cladribine, and we haven't seen a major viral infection or severe viral infection signal, unlike alemtuzumab where we do. So there are differences between these two, and I don't personally think Cladribine should be classed in the same bracket as alemtuzumab in terms of its risk associated with immunosuppression. What's important is B cells also go down with alemtuzumab. They go down much, much further with Cladribine. Actually, B cell depletion is in the zone of 85 to 90%. And what's important is that the population of memory B cells is depleted even quicker and more profoundly than the overall B cell population with Cladribine. And the level of depletion between alemtuzumab and Cladribine of the memory B cells is equivalent. And it stays flat for possibly years after dosing. So there are quite subtle differences between these two agents. Another big difference between these two agents is that with alemtuzumab, monocytes go down for the first 2 or 3 weeks before recovering, and we don't see any significant change really with cladribine. And so I did mention to you in the beginning of this presentation that when you've got a lymphopenia with a monocytopenia, it puts you at risk of other infections, particularly bacterial infections, fungal infections, and opportunistic infections. And so we haven't seen that profile of infections with cladribine where we see that profile with alemtuzumab, which is why we have to do things like listeria prophylaxis. And most of us now have started using cotrimoxazole prophylaxis in addition to dietary advice. The good thing about cotrimoxazole, it also covers nocardia and pneumocystis, which have both been linked to alemtuzumab treatment. So this tries to summarize the differences between the depleting. As you can see, alemtuzumab is like a non-selective depleter. It just leaves the neutrophil counts relatively intact. Cladribine is semi-selective in that it takes down mainly B cells, takes down some of the T cells, whereas ocrelizumab is probably the most selective, really just taking down B cells mainly, and a small population of T cells. My personal opinion is, based on the depletion characteristics of these three agents, is that cladribine is probably closer to ocrelizumab in view of its safety profile from the clinical trials. The small zoster signal, no other major viral signal, and no severe viral signal, whereas with alemtuzumab are very, very different. And this is why I've come forward saying we shouldn't be using alemtuzumab while the COVID-19 pandemic is running, but I don't see any reason why we shouldn't use cladribine and ocrelizumab, either starting or redosing in the current climate. So now, how do we de-risk for COVID-19? So I actually put this table out, which was published in MSARDS, dividing up the agents into 4 categories based on subtleties. Okay. My personal opinion is, in terms of immune function and lymphocyte counts, interferon, glatiramer, and teriflunomide are safe. I've put dimethyl fumarate and natalizumab there. The dimethyl fumarate really refers to those patients that don't have lymphopenia lower than 800. I put the S1Ps, anti-CD20s, and cladribine in the next group, and high risk was the depletion phase of mitoxantrone and alemtuzumab at HSCT, which is the 3 categories of treatment that we aren't using at the moment. I got this published, so you can read about it. I subsequently updated it to version 3, where you can see that I've actually included in the top line as low people that have reconstituted post-immune reconstitution therapies, to make it simpler. And I've put dimethyl fumarate there, and I've also made the point that depending on the level of lymphopenia, dimethyl fumarate could move into a more high-risk category if there was significant lymphopenia associated with it. Anyway, since then we've got more data, and so you probably read this paper. It came out in Lancet Neurology last week. It's the first 232 patients with MS developing COVID-19. The good news is that the patients did remarkably well. Based on population figures, it doesn't look like MS patients are at increased risk of COVID-19, and it doesn't look like MS patients are at increased risk of severe COVID-19. And patients were on a spectrum of disease-modifying therapies. I think there's too few DMT, there's too few patients per DMT to be categorical about this, but overall, patients have done very well. In my personal opinion is, I think our therapies are quite mildly immunosuppressive and are unlikely to blunt the initial antiviral responses. And therefore, most people who get COVID, with MS who get COVID-19 are going to deal with it reasonably well. Of the 10 patients that they classified as severe that went into intensive care, 5 unfortunately died, but you can see the 5 that died tended to be much older. Okay, much higher EDSS scores. Okay, where's the deaths? The the deaths were all in the top one, sorry, the 5 in the top of the deaths, you can see they're all high disabilities, 6.6, 6.5 and above. Almost all of them were relatively old, only one under the age of 60. 2 of them were no therapy, 3 with no therapy, 1 on DMF and 1 on rituximab. Okay, so my message going out is that tell your patients that it looks like if they do get COVID-19, they're going to deal with it relatively well. The patients that have died have appeared to have died from the risk factors that have been identified in the general population: older age, comorbidities, and in the case of MS, progressive disease, more advanced disability. Another bit of data that's come out and that may be relevant to this discussion is the ITU data, just showing you that the proportion of people that are getting into intensive care unit with COVID-19, only 2.3% were immunocompromised. And this is about 4 times lower than a comparative group that were admitted to intensive care units in the UK with viral pneumonia. And so this would suggest that potentially being immunocompromised actually protects you from going into intensive care unit. If immunosuppression or being immunocompromised was a problem, you would have expected this figure to be in the same proportion to other viral pneumonias. And so this raises this issue, is that maybe mild immunosuppression is beneficial. In other words, it protects you from getting that second phase, that adult respiratory distress syndrome, or that cytokine storm that causes the lung pathology. And that's probably one of the reasons why there are so many trials going on now testing immunotherapies in more advanced COVID-19. Steroids, Natalizumab, anti-IL-6 receptor. There's one looking at a fingolimod trial. There's one neutralizing antibody against gamma interferon. When you look at the RA literature, the rheumatology literature, it looks like people that are on anti-TNF therapies and on JAK inhibitors, which is another anti-inflammatory, they actually have a much lower risk of getting severe COVID-19 as well. So there's lots of this little incidental data coming in suggesting that potentially mild immunosuppression is protective against severe COVID-19. Anyway, there was a case report that came out a couple of weeks ago showing a patient with quite advanced primary progressive disease, got COVID-19, had been on ocrelizumab, had no B cells in their peripheral blood, recovered without any complications from COVID-19. So this actually supports that observation about the A-gamma globulin patients with no B cells also recovering. Vaccine readiness. So I've actually upgraded my DMT table to version 4 now, and I've added a column called vaccine readiness. And the 3 agents that really will put you at risk of not having an immune response, okay, is anti-CD20, because it's a continuous. I put Cladribine there, possibly blunted. And the reason is we don't have vaccine data on Cladribine. But once the immune system reconstitutes post-Cladribine, vaccine responses should theoretically be intact. Okay. S1P modulators I've also put as blunted, and I've also put Natalizumab is likely to be intact because there is vaccine data available. So Cladribine probably should be a different color to red here, because it depends on what stage the person's at. So if you treat a patient and they've had their second course and they've reconstituted, that should be green. If you treat a patient and they're still in the lymphopenic phase and they haven't reconstituted, that will probably be in the orange phase, because the level of depletion with Cladribine is really below 500, where you wouldn't be able to mount an immune response. And obviously, mitoxantrone and alemtuzumab HSCT will be blunted again if it's in the depletion phase. I just want to highlight to you that when you look at a total lymphocyte count post Cladribine, for example, it doesn't tell you the whole story. So you can see there the lymphocyte counts with 2 courses of Cladribine. Most patients, almost all patients, recover their lymphocyte counts above 1 with time. At 144 weeks, 75% are above 1. But what's important is when you look at the depletion kinetics, it's the B cells that have gone down, and the CD8s tend to not be that depleted, okay, compared to the CD4. So I'm beginning to think of Cladribine as possibly one of the better agents to use in COVID-19, particularly if you want to start new patients on treatment, because it leaves them vaccine ready. In other words, they have a peripheral lymphocyte count in a zone that will allow them to make immune responses to a vaccine, and they potentially could get a live vaccine. And the reason why I say that's important, because some of the vaccines that have been developed right now for coronavirus use a viral vector to express the immunogen. So the Oxford vaccine, for example, uses a chimpanzee adenovirus to express the spike protein. So it's not good enough to be on a therapy that allows you to have vaccines, component vaccines. You also have to be on a therapy that allows you to potentially have live vaccines. So that's something we have to keep in mind. Just to point out, with Cladribine, it doesn't affect the innate immunity to any significant degree. So I've got this table, which I've published as well. It's how we de-risk the therapies, baseline in terms of infusion and monitoring. And this has to be altered and highlighted in terms of the COVID-19. And so in terms of the COVID-19, you know, which of the therapies allows you to do things remotely, allows you to limit the baseline screening, not have infusion reactions, and have low monitoring requirements afterwards. And I thought Cladribine is probably the agent, in my opinion, in terms of the high efficacy agents that emerge as being, you know, a really appealing therapy going forward. The other one would be Natalizumab. The problem with Natalizumab is it requires patients to come to the hospital center for their infusions. So they get exposed to potentially a COVID-19 hot environment. And so I did a blog post on this about last week, just showing you that when it comes to ticking criteria for managing MS in the COVID-19 pandemic, Cladribine is a very favorable agent. It's oral, so you don't have to have hospital contacts. There's no cell lysis syndrome, therefore no steroids. Innate immunity is intact. There's only a moderate reduction in T cell counts. CD8s are left relatively intact for fighting viral infections. So antiviral immunity is intact. There are low monitoring requirements. There's only a small risk. Now in the trial, 25% of patients dropped their counts below 500, but with the modified dosing schedule, in other words, by delaying the second course until the lymphocyte counts recover above 800, that's going to be less than 5% of patients below 500. And when they do go below 500, it's very transient for a short period of time. Other advantages is that CNS penetrant, post-dosing immune reconstitution will allow a vaccine-ready population, and I'd argue that it's a high efficacy DMT as well. So there are lots of favorable aspects around it. So to conclude then, disease-modifying therapies can be classified as either maintenance or immune reconstitution therapies. If you are discussing the IRTS, please don't just lump them together. There are selective ones and non-selective ones, okay? I think it's important that when you think about the impact on the immune system, there are those that are modulatory, don't cause immunosuppression at all. And if you are immunosuppressive, it's either long-term with the maintenance ones or short-term, completely different risk profile. Lymphopenia is important, but it's context specific, okay? It depends on the level. Qualitative changes, does it affect CD4, CD8s more? Temporal profile, let me give you an example of a temporal profile. If somebody is started on Dimethyl Fumarate, and you do their 3-month lymphocyte count and it's 860, and you do their 6-month one and it's 560. That to me is on a downward trajectory. That's more worrying than somebody who was treated with, say, Cladribine or Alemtuzumab 3 months ago, where we had a lymphocyte count of 0.1 at month 1, it's now 0.3, and it's now 0.56. That 0.56 post-Alemtuzumab was on an upward trajectory, improving, whereas with DMF, it's probably on a downward trajectory. So you'd interpret those exact two lymphocyte counts completely differently because of the temporal profile. Okay, there's just no shortcuts here. You have to have disease-modifying therapy specific knowledge, and you have to understand the dynamics for each agent. And this is extremely relevant for COVID-19, not only about making it safe if somebody got the infection, but also thinking down the line that if a vaccine does emerge, how are we going to make sure or consider that making your patient vaccine ready? Now, I'm not saying we should switch treatments, but if somebody is on a long-term anti-CD20 therapy, you may want to delay dosing to allow some B-cell reconstitution so that they can mount a good antibody response to the vaccine, for example. Okay. I've already mentioned de-risking strategies, slightly different in the context of COVID-19. The immunosuppression, particularly viral immunosuppression, is very important. And that's one of the reasons why we stopped dosing alemtuzumab. And we've also stopped our HSCT program at our hospital. And that will have to be recommenced later on when the risks in the general population of becoming infected with the virus drop. And I'd encourage you all, please don't forget to database, put forward all your patients that who've got MS and developed COVID-19. We need to put them into our UK MS registry database. There's the patient one and there's the clinician one, so we can learn from our own experiences. And then education is the motto. I think we learn as more data comes in. So please keep yourself plugged into some form of rapid learning, because the data is coming out literally on a daily basis around COVID-19 and the immune system. And so our guidelines are going to change quite rapidly. Just to give you an example, we've already had 2 renditions of the ABN guidelines. We're going to get a 3rd rendition probably in a couple of weeks' time, changing things. So it's a rapidly moving area. And I'll leave it there and take questions. So this is from an anonymous viewer. Why do you think we should never use a live attenuated vaccine in natalizumab treated patients? So I think the regulators were worried about it being neurotropic, for example. So if you give somebody a live, so polio vaccine, for example, and it does seed into the central nervous system, you're not going to be able to clear the virus and it'll cause polio. So that's it probably refers to neurotropic viruses. And so so you'll be a brave person to give somebody on natalizumab yellow fever vaccine, for example. I think by having them on extended interval dosing, that risk goes down, but I'm not sure you can say it goes away. And I think that's the reason. It's got to do with, there's a compartment that is protected from immune surveillance. Lorna is next. Based on what you explained about lymphopenia and reconstitution, should we start alemtuzumab or keep waiting? Yeah, so my personal opinion, if you're going to use alemtuzumab in the current environment, you've got to realize that that person's lymphocyte counts are going to be low in terms of antiviral responses for about 3 or 4 months and maybe longer. In a young person, that's probably a count of 500, and a person over 60 is probably 800. And so that person is going to have to shield or self-quarantine until their lymphocyte counts recover to above 500, so you can be confident they can mount an antibody response. With Cladribine, very few people are going to go below 500. So what we will do is redose with Cladribine and possibly do an extra blood test. Because at the moment you do a blood 1 month after the second cycle, and that is the nadir. And the number of people that will be below 500 there will be about 1 in 20. If they don't drop below 500 there, they're fine, in my opinion. They don't need to shield. So with Cladribine, very few people will have to shield. And then you could just repeat the blood test until you see they're above 500 and tell them to stop shielding. We're going to have to start using alemtuzumab soon. As we flatten the curve and we extend the tail, and we have this COVID-19 pandemic and the virus around for years, potentially years. At some point in time, we're going to have to start using alemtuzumab, and I think what we then have to do is use it with shielding. This is from Elaine. If someone had a first round of Lemtrada and their second round has been delayed, could they start Cladribine? Yes, I think there's no reason why you couldn't switch them from alemtuzumab to Cladribine and give them Cladribine. It's a reasonable one, because if you're thinking about making sure that they are treated from the MS perspective, yes, it would work. And it also would potentially leave them vaccine ready when they came out of the when the vaccine arrived. We had an experience of the suspected COVID-19 post-Mavenclad during depletion phase with lymphocyte count of 0.2. They made a good recovery. We needed an antibody test to prove this was a definite case. Yes, so you're not the only one. I'm aware of a few patients that were still depleted post-Cladribine and alemtuzumab. There was a case in London, alemtuzumab. Their counts were also in the 280-something post-alemtuzumab. Made a very good recovery. So although I'm setting in my head the threshold at 500, it's quite clear that you can make antiviral responses with lymphocyte counts below 500, but it's all about being safe. So you don't want to have no lymphocytes when you get COVID-19 because you do need the lymphocytes to counteract the virus. Here's my friend Helen from Chelmsford. Hi Helen, we have 2 patients who are waiting for their year 2 course. Can we give this a year 2 course of Cladribine? Yes, yes, I think we've taken the decision internally to counsel our patients. If they're prepared to go ahead, we're giving year 2 course of Cladribine. Anonymous, with immune reconstitution therapies, after immune reconstitution, do you think that the qualitative change in the lymphocyte profile, namely depletion memory, can also impact on response to infection? Yes, because, let's be correct. What happens is memory Bs, a proportion of them go off to make plasma cells, and plasma cells are long-lived, okay? And they don't have the biology. We don't think Cladribine targets plasma cells, and we don't think alemtuzumab targets plasma cells because they don't express CD52, and we don't think anti-CD20 or anti-CD19 therapies. So those plasma cells will continue to make antigen-specific antibodies, but those plasma cells don't live forever. They're long-lived, but they live decades, not lifetime. So they have to be replenished. So yes, in the long term, continuous B-cell depletion will result in antibody responses dropping off, but not in the short term. Okay. So unless you can make new memory Bs, you can't really make good quality antibodies for memory responses. So that's why when it comes to discussing vaccine readiness, we have to rethink our strategy in terms of the vaccine. Do you think that self-isolation that has been recommended to, this is from another anonymous viewer, to immunocompromised patients may somehow contribute to the small numbers? Yes and no. Let me give you an example why I say no, is because when you look at the transplant patients, there's been case series now coming out of liver transplant patients and renal transplant patients. And in that population, the proportion of people getting severe COVID-19 is small, so smaller than you'd expect. The exception is when people got very low lymphocyte count. So there is a treatment they use in renal transplantation where they use ATG, antithymocyte globulin. That's a potent depleter of T cells. The people that had ATG and had low lymphocyte counts had a very high mortality. And I suspect the reason is because they had no T cells and they couldn't mount an antiviral response. But in the other compartment where they weren't on ATG and they had T cells, so these are patients on tacrolimus, on mycophenolate, and those therapies, they seem to have had a lower risk of getting severe COVID-19. So I personally think immune suppression or mild immunosuppression protects you from the second phase, the lung infiltration. We now know that the lung infiltration is driven by innate immunity, monocytes, IL-6, and then subsequently T cells with the T cell cytokines. Okay, so something that does reduce lung entry, lung inflammation may be beneficial. If the COVID-19 vaccine comes onto the market, can we use in our MS patients? Do we need specific selection criteria? Thanks in advance. So yes, so what will happen is if it comes onto the market and it's a live viral one, we're not going to be able to use the vaccine in Natalizumab patients because of the label, fingolimod, sulfonamide treated patients, okay? We'll probably be able to use it in, or ocrelizumab, anti-CD23. We'll probably be able to use the live vaccine in people that have had alemtuzumab, HSCT, or Cladribine, provided that they have got immune reconstitution. If it's not a live vaccine, if it's a DNA vaccine or a nucleotide vaccine, also RNA ones coming out, or that comes, or it's a component protein vaccine, we'll probably be able to use it in all our patients because there's no risk of infection from the virus. But there, the chance of responding is going to be blunted in people on long-term immunosuppression. So people on fingolimod or S1P modulators, people on anti-CD20 therapies, people that are still depleted post-Alemtuzumab, post-Cladribine are going to have blunted immune responses there. So it all depends on the agent and where they are in terms of their peripheral reconstitution. Yes, so we would give Cladribine. We would recommend shielding until they get their first blood count, which is at month 3. And if that blood count's above 500, we would stop shielding. If that blood count's below 500, we would say continue to shielding, and we would check a blood count again in 4 weeks after that. The good thing in London is we managed to sort out, which we'll put our patients into, home phlebotomy, where a phlebotomist goes into the home, takes a blood, takes it to the lab, and we get the result a day later. So the problem with using full blood counts to shield or not shield is that the patient has to go to a healthcare facility. Ideally, you don't want them to come to your hospital unless you've got a clean phlebotomy section. You probably want them to go off to a GP or a clean phlebotomy service. So it depends where you are in the country. Some general practitioners are separating out their practices into COVID hot, where people are suspected of having potential COVID infections, and COVID cold. And so you'd want to send your patient in a general practitioner network to the COVID cold practice or healthcare facility.
Great.
No other questions?
That's all the questions for today. So thank you very much. Thank you everybody for joining us, and we'll see you on the next webinar.